in this two-part CMEO cast series titled Getting the Jump on Tardive Dyskinesia, Real-World Strategies for Detection and Optimal Management. Today's episode is titled Using Measurement-Based Care to Improve the Accurate Early Detection of TD, a very important component of the management of TD. This podcast series is supported by an educational grant from Teva Pharmaceuticals. I'm Christoph Correll, Professor of Psychiatry and Molecular Medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell in Hempstead, New York. I'm an investigator at the Center for Psychiatric Neuroscience, Feinstein Institute for Medical Research in Manhasset, New York, and I'm also working at the Zucker Hillside Hospital Department of Psychiatry in Glen Oaks, New York. I'm very pleased to be joined today by my esteemed colleague, Juhi Jimenez-Shahed, Medical Director of Movement Disorders, Neuromodulation, and Brain Circuit Therapeutics, and Associate Professor of Neurology and Neurosurgery at the Icahn School of Medicine at Mount Sinai, New York, New York. Welcome, Juhi.
Thank you so much, Christoph. Glad to be here.
To frame the discussion today, let me review our first learning objective. Our goal is that after this CMEO cast episode, you will be able to assess the impact of antipsychotic-induced TD on functioning, quality of life, and the underlying psychiatric disorder. Juhi, let us start here. Tardive dyskinesia is an umbrella term used to refer to persistent hyperkinetic, hypokinetic, and sensory phenomenologies related to chronic exposure to dopamine receptor blocking agents. Can you briefly give us a breakdown of the terminology?
Yeah, that's a great place to start, Christoph. I think people sort of use the umbrella term tardive dyskinesia to refer to a number of different things, and it's important to sort of understand that it is an umbrella term. There are a number of different phenomenologies of abnormal movements that fall within the category of dyskinesia. Just remember that the word dyskinesia means abnormal movement. It's a very generic term, and as a neurologist, and specifically as a movement disorders neurologist, we like to characterize movements a little bit more specifically. So what is generally considered to be classic tardive dyskinesia actually is the orobucolingual stereotypies that we're familiar with, right? So the lip smacking, the tongue movements, jaw movements, things like that affect kind of the lower face. That's probably one of the more common manifestations of tardive dyskinesia, but it is a stereotypy. And a stereotypy is just a kind of coordinated, repetitive, sometimes seemingly rhythmic, but largely purposeless movement that people do kind of repetitively, sometimes even without even knowing it. And other stereotypies can be things like finger rubbing or kind of rubbing the legs or pulling at the shirt. These are all different types of repetitive movements that can fall into this category. But there are other features of tardive dyskinesia, and some of those can include things like chorea. So chorea is an involuntary movement that is non-patterned, and it moves unpredictably from one body region to another. And sometimes we might actually miss this manifestation of tardive dyskinesia if we have patients sitting in the chair with their feet on the floor. So usually I'll have them sit up on the examination table with their legs unsupported, and then you might see these sort of fidgety movements that occur either in the upper extremities or even in the lower extremities, and that's more of a chorea. Dystonia can also occur as a phenotype of tardive dyskinesia. So we have this entity that is often referred to in the literature and certainly in the clinical sense as tardive dystonia. And this is where patients have sustained contractions of a muscle or group of muscles that creates an abnormal posture. And the dystonia itself can be very focal. It can involve the eyes, it can involve the jaws, it can involve the neck, or you can have more generalized forms of dystonia. And one of the very classic tardive dystonia phenotypes is the patient who has epistotonic posturing, where their trunk is extending, their neck is pulling backwards, their shoulders are rotating inwards, and they look and they are quite uncomfortable when this occurs. And so that's another important one to recognize. And then the last one, you kind of referred to sort of a sensory component. And when people have tardive akathisia, then this is also sort of another kind of subgrouping that falls under the umbrella of tardive dyskinesia. And these patients just have this subjective feeling of motor restlessness, and they have to move. They kind of feel the urge and the need to do that. And they're the guys that are kind of pacing around your office and unable to sit still, getting up and down, things like that. Again, quite uncomfortable for patients. But, you know, all of these terminologies sometimes can be incorrectly kind of interchanged. But I think it's important to be able to have an appropriate conversation about the different phenomenologies that we're seeing.
Thank you so much. This was a wonderful starting point, and it's so great to have a movement disorder specialist and neurologist with us. So just to remind the audience, the dyskinesia just doesn't only mean the chorioarticuloid movements that we're used to. That's why I think neurologists want us to call this more tardive syndromes to identify tardive dyskinesia, the classic stereotypic movements as tardive dyskinesia, but then differentiate tardive dystonia, akathisia. Yes. But also, you guys don't like us to talk about extrapyramidal side effects either, because there's Parkinsonism, which is one thing, the rigidity, the tremor, and there are other akinesia, there are other phenomenon. So what we see though is it's not a tremor, it's not a rhythmic kind of a movement. Yeah. That's not tardive dyskinesia. And it can be quite uncomfortable, and it can be also internalized, and we need to look for it. And that's what we're talking about here. So tardive dyskinesia is really more than just annoying movements. It has also other components. It's quite widespread, correct? You said it's multiple body regions we need to examine.
I think that we should look in multiple body regions. You may find that a person's tardive dyskinesia is restricted to one area or another, but quite often, unless you look for it, you might miss the fact that there are other movements going on in other areas. So you're absolutely right. A whole body examination is important in this condition.
And then it affects more than just the motor symptoms and system. So people are affected in multiple ways. Can you go a little bit into detail about that?
Sure. I mean, I think, you know, it starts with the movements and what is, you know, kind of a product of those movements, right? So if somebody has, you know, mouth movements, tongue movements, jaw movements, maybe that's affecting their speech. Maybe it's affecting their ability to swallow. Maybe it is giving them pain or discomfort in their jaw, their TMJ joint. So these can often be the downstream consequences of having those involuntary movements. In the upper extremities, if patients do have chorea or dystonia or maybe even akathisia, it can affect their fine motor skills and their ability to kind of conduct the tasks that they need to do in a day. Maybe their activities of daily living are impacted because they're moving, you know, in an uncoordinated way. So it's taking them longer to do things. Maybe they can't write as well as they used to. So all of these, you know, manifestations are troublesome in their own way as a consequence of these involuntary movements. And then, of course, we talked a little bit about the dystonia and how having that truncal movement can really impact, again, causing pain, but then it can also impact gait and balance and walking. And so people may have difficulties with just that type of routine getting around, or it may also impact their ability to exercise and to feel comfortable at night when they're sleeping. And again, all of these have downstream consequences and adversely affect patients.
And these downstream consequences can also affect our mood and how we see the world, as well as cognition, can't it?
Absolutely. I mean, I think patients, you know, certainly, you know, can be distracted by the movements. They can be very aware of the movements. They can feel very self-conscious about them. It can add to their anxiety, perhaps even, you know, some fear or paranoia or worry about going out in public and other people seeing them in that state. So that does. I mean, I think, you know, there's often social stigma associated with tardive dyskinesia as well. And I think all of these things can adversely affect a patient who already has an underlying psychiatric disorder that, you know, was associated with the development of their tardive dyskinesia.
Absolutely. So we have several layers around the actual movement that is only at the core of it. So what about some social media listening study that was just recently published? What did it tell us about some of the patient perspective?
Yeah, this is a very interesting kind of methodology, right? So it's the idea that you are trying to understand patient experiences by reviewing their completely unsolicited sort of statements about the condition that they're dealing with. And in this particular investigation, they had 261 posts that they were able to identify as being associated with a condition like tardive dyskinesia, and it was both from patients as well as caregivers. And I think some of the common themes were that patients were quite angry about the development of this condition, and maybe frustrated that they took a medication for one condition and then it caused another problem, and that's certainly understandable. I think these symptoms affect their day-to-day functioning, and another finding was just that they're really relating the difficulties that they have in day-to-day life to the presence of these abnormal movements, often describing it as a terrible experience, in fact, and that there's a great deal of suffering associated with this, whether it's personal suffering or psychosocial or environmental or job related, what have you, a number of different factors there. Another, kind of main theme from this investigation of social media posts was insecurity, and patients feeling, that they were somehow singled out or weird or different. And that, of course, can be a very unsettling experience for patients as well, and how, this might make them feel unaccepted by society or uncomfortable in who they are. It's not really them. That maybe they'd even rather be dead. And these are some pretty strong feelings that patients are associating with the involuntary movements that they have developed as a consequence of this condition. And certainly, the biggest part of this is that fear of judgment, or fear of people noticing and calling them out on whatever manifestations they have.
Yeah, so it's very stigmatizing, and it's basically in your face. That's how we communicate. That's how we judge people. I passed borders once and people saw that I'm a doctor in my passport. And the guy asked me, what's your profession? I said, I'm a psychiatrist. And the way he responded was, so he was twitching, equating this with mental illness. So it's quite disturbing when this is happening as a side effect. Now that we've discussed the impact of antipsychotic-induced TD, our second learning objective is to incorporate measurement-based care in the detection and monitoring of TD, which will then be the basis for actually management in our second component of this program. So let's begin by highlighting some risk factors that are associated with TD.
Yeah, I think tardive dyskinesia, certainly, as we'll talk about in later in this segment or the next one, is a condition that is commonly associated with those dopamine receptor blocking medications. It is highly prevalent regardless of the type of medication that you're taking. But even so, there are some risk factors that put individual patients at greater risk. And you can categorize these as either modifiable risk factors or unmodifiable risk factors. And I think the unmodifiable ones are particularly important when we're thinking about that initial prescription with the dopamine receptor blocking medication. And are there individual patients who maybe we should either think twice or be very careful about the use of these medications, or maybe even monitor them even more closely because of these known risk factors. And some of these are patient related. So for example, older patients, female patients, individuals of wider African descent tend to be more commonly experiencing tardive dyskinesia. So, we want to keep our eyes wide open, especially when counseling and treating these groups of individuals. Others are illness related. And so we know that people who have longer illness duration for which they might need to be treated with these dopamine receptor blocking medications are more likely to develop tardive dyskinesia. Individuals with underlying intellectual disability or brain damage, patients with schizophrenia who have prominent negative symptoms, individuals with mood disorders, and even within the group of patients with mood disorders, those who have underlying cognitive disturbances. These are patients who we know seem to have a greater risk of developing tardive dyskinesia. And the one really kind of unmodifiable one that is hard to mitigate is those genetic polymorphisms that we know can be associated with increased risk. And that is hard because it's not always easy to test for these. But it's important to recognize that there is this heterogeneity in the population, and sometimes despite our best efforts, there might be these underlying factors that also contribute.
But there are also actionable items, correct?
Yep. Yeah, absolutely. So when we have patients in front of us who have diabetes or who are smoking or who maybe are using substances, again, these are conditions that are associated with increased risk. And these are things we can counsel our patients on and say, look, we know that you need to take this medication. And one way to reduce the risk of this abnormal movement disorder is to modify these and make sure your diabetes is controlled. Think about smoking cessation or ceasing substance use and abuse. Then there's other modifiable ones like the choice of the dopamine receptor blocking agent. And we'll talk a little bit more about that in subsequent slides. Patients who have been taking these medications before and have already developed some of the Parkinsonian side effects of those medications might be at greater risk. So we want to be extra careful either in prescribing or in monitoring patients like that. Patients who have already experienced akathisia. Another important one that I think is not always frequently mentioned is patients who are taking anticholinergic medications. I think there's a common practice of co-treating patients with a dopamine receptor blocker and anticholinergic. And in the context of tardive dyskinesia, it's important to remember that the anticholinergic can actually worsen the dyskinesia. And so maybe thinking about stopping those medications at that time. And then lastly, I think it stands to kind of reason, given the disorder, that higher cumulative and current antipsychotic dose definitely increases risk. So we want to be treating patients with the right dose for the right condition.
Yeah, so I hear loud and clearly, and I hope the audience can appreciate that we should not treat until the neuroleptic threshold, until people have EPS, and then tolerate this by giving even an anticholinergic. We need to be below the Parkinsonian threshold, akathisia threshold. And if people cannot be stabilized without these side effects, we may need to move on to an antipsychotic that doesn't cause these side effects. And first generation agents are just at higher likelihood of causing TD. So unless it's necessary for some reason, we should go with second generation agents.
No, now, I think that's a good point, but we'll talk about that too, right? I mean, it doesn't absolve you of risk either to be using the second generation antipsychotics.
Absolutely. It's about relative risk reduction. So given the quality of life and functional impact of TD, an early accurate diagnosis is imperative. So what are the diagnostic criteria for TD?
I think the most sort of salient and applicable and easy to use is the DSM-5 criteria. So the DSM-5 tells us that a clinical diagnosis of tardive dyskinesia can be made when a patient is experiencing involuntary, either athetoid or choreiform movements, and those are those kind of flowing movements that we talked about, that are lasting at least a few weeks. And developing in association with the use of a neuroleptic medication. So first and foremost, if a patient has involuntary movements, are they taking or have they been exposed to a neuroleptic? And that's your first step. Beyond that, then we have to consider sort of the onset of these symptoms in relationship to the dosing of those medications. So sometimes these movements can occur, we call it tardive because it occurs later. It doesn't necessarily happen at the time that somebody begins treatment with a neuroleptic medication, but it can emerge after dosage reduction or discontinuation. And this is also a feature that's mentioned in the DSM-5 criteria. So we need to be mindful of that. And if somebody's withdrawal emergent dyskinesias are persisting beyond 4 to 8 weeks, then we really need to be thinking that this is potentially a more permanent tardive dyskinesia type situation. And the other sort of feature that is highlighted in the DSM-5 is that certain patients, especially older patients, might develop tardive dyskinesia after shorter duration of exposure.
So there can be dyskinesia on antipsychotics, but also off antipsychotics, which can be an overshooting withdrawal syndrome, but it might also be an unmasking of the TD that was underlying the dopamine blockade that was there before.
Yeah.
Okay. And now I think what's important for our audience to learn is really what's the differential diagnosis. And here as a neurologist, you can bring a lot to bear where we may not pay attention to or think of, and also who should we refer to? What tests should we do?
Yeah, this is sometimes a difficult question. I think that, tardive dyskinesia, we've talked about the diagnosis requires exposure to a neuroleptic medication or an antipsychotic medication, and then the presence of the involuntary movements. So if you see somebody who has involuntary movements and either has been treated with or then is currently being treated with neuroleptic, then obviously this is what we're thinking about. But there are certainly other neuropsychiatric conditions in which that combination might exist, right? So if you have certain, neurodegenerative disorders where there are, or neurodevelopmental disorders even, where patients may have behavioral disturbances and they may have, excessive involuntary movements that required treatment with a neuroleptic, then being able to differentiate those from a tardive dyskinesia, for example, somebody with Tourette syndrome or somebody with Rett syndrome, for example, even some cases of, patients even with Wilson's disease, which is a copper handling problem. They may experience these types of psychiatric issues that then manifest with movement disorders. coexistent with that, and they may have also been treated with a neuroleptic. So sometimes when we are evaluating these patients, obviously the first and most important part of this in the differential diagnosis is getting the appropriate history. What was the onset of the exposure to the medicine? What was the onset of the abnormal movements? Did it occur, with the dosage change or something of that nature? Or is there a family history of other, similar disorders in the family? So some of these are definitely screenable, but I think, with laboratory tests, but you really want to think carefully about which tests you want to order based on the manifestations. Another, important consideration in situations like this would be, especially in an adult patient, would be something like Huntington's disease, where you can have that triad of cognitive disturbance and involuntary movements, and psychiatric changes. And Huntington's is also testable with a blood test, but often has a family history. And so you would be clued into testing for that by taking an appropriate history from the patient and about their family. A couple of other interesting differentials to consider. There are patients who will develop orofacial and lingual movements as a consequence of dentures, or maybe not having their dentures. And this is a common one that comes up. And I think, important to investigate whether or not the person with these movements is also experiencing discomfort from their dentures. And then on the other side of things, like on the more sort of maybe neurologic side, where there aren't always clear psychiatric manifestations, there are some drug-induced dyskinesias. So for example, a Parkinson's patient who's taking excessive or just long-term use of levodopa will develop dyskinesias that can look very choreiform, sometimes even dystonic. And so knowing that history would be important because that would be an important differential. There are other drug-induced movement disorders that can come from things like SSRIs or lithium or tricyclic antidepressants. So these would be, again, appropriately screened for during an evaluation. There are a number of other ones. I think, restless legs can sometimes be difficult to differentiate from akathisia. But an important differentiating feature is actually the diurnal variation in restless leg syndrome. They're predominant in nighttime when patients are trying to go to sleep, and relatively quiescent during the day, unless there's periods of inactivity when those restless legs. And so it's discontinuous, whereas an akathisia is really kind of all the time.
So it's a long list.
Yeah, it can be.
It's a long list to consider, but I hear that we want to do a good history, take a good history, which involves family history and also when it occurred. And we also see that there can be an overlap with other conditions. Tourette syndrome, that would be a much faster, quick, like a tic-like symptom, but then patients get antipsychotics for the tics and can develop, in addition, tardive syndromes, which is important to differentiate also. Now, the APA guidelines have also some catchy phrases, what you should do. Can you review those with us?
Yeah, so I think first and foremost, I think whenever you're sitting in front of a patient who either requires a dopamine receptor blocking drug or you're considering treating or changing that medication, is to screen them, right? So just look at your patient, right? I think this is a very visual phenomenon. And if you aren't looking, you won't see it. So taking a look is always a good idea, and just really screening those patients appropriately. And once you screen, then you should monitor patients in the long term. And monitoring, again, looking at patients each time that they come in, and at least briefly examining what their movements look like, so that you know whether or not there's reason to dig further. When you determine that there's a reason to dig further and try to understand what these abnormal movements are, you can conduct a structured tardive dyskinesia assessment. And these are recommended to occur every 6 or 12 months, depending on a person's drug exposure and their risk profile. But you certainly would want to conduct one of those standardized assessments anytime that there was suspicion of an involuntary movement. And then lastly, if you are not necessarily the treating clinician, not the medical managing person, to consider a diagnostic evaluation and referring that patient for a complete kind of biopsychosocial assessment of what is going on with these abnormal movements and how they play together with the psychiatric condition and the treatments that patients have been receiving.
So while a tardive dyskinesia focused assessment might occur every 6 to 12 months, actually the screening and monitoring occurs at every visit. You look at the fingers, you look at the face, and it starts when you get people walking into the room, because then you can already distinguish some of the abnormal movements.
Yep, you're absolutely right.
So an advisory panel of experts in psychiatry and movement disorder neurology convened to develop recommendations on assessing the impact of TD in patients' functioning. What are some of the key highlights here?
Yeah, so the panel got together and discussed some key important points in tardive dyskinesia. And the first we've already talked about, right? I mean, the importance of assessing for tardive dyskinesia. And so it's important to look for it, because if you don't look for it and don't recognize it, then you won't know how to treat it, or whether you should treat it, or how to optimize the treatment for it. Another important feature of this kind of assessment is getting a sense of how much the symptoms are impacting a patient, because that will guide your decision making, your level of urgency in terms of implementing treatments, things like that. And the other part of this was a kind of importance of gathering information from multiple sources. As we'll talk about, patients may not always be aware of the movements that they have, and so getting input from family or caregivers or staff at facilities that are regularly interacting with patients can be really helpful in determining what's going on. Another consensus recommendation was that there were some key domains to assess. So not only do we look for the movement, but then we should also look for the impact of the movement. How is it affecting social functioning? Are there physical consequences? Are there vocational or psychological or psychiatric consequences of patients experiencing these movements? And then from the standpoint of when to assess, as we've already said, every patient visit, you should be taking a look and being observant. And then lastly, what kind of approaches can be used to assess patients? The consensus was obviously to assess across those key domains that we mentioned, and talking to the people around the patient in terms of family, caregiver, et cetera, to get that information that will allow you to make that diagnosis.
So we can glean an important message from this consensus, that it's not always the patient telling us about the movements, because they may not be fully aware of them. We need to look for them, but also we need to ask about impact and ask about this kind of movements with people who are living with the patient, or at least seeing them. But then when we've determined we want to or need to do an assessment, what kind of rating scales are actually available to do that? And which one should we use?
I think the most commonly used one, and probably the easiest to use, is the AIMS, right? So the Abnormal Involuntary Movement Scale. And this is a standard assessment. It's well described. There's many, sort of resources out there where you can get your hands on a copy of the AIMS, but it's an observer rated scale. There's 12 items, and there's anchors for each of those items. 7 of them actually rate different body regions. And so you will look at, for example, the facial and oral movements, and you will decide if there's mild, moderate, severe movements. You'll look at the limbs and the extremities to see if there's movements there. And then finally, you'll look at the neck, the shoulders, and the trunk to see if those are moving. And you can rate the severity of the movements in all of those areas. One interesting thing about the AIMS is that it allows for some like if you're observing a patient, you're not quite sure if it's an involuntary movement, you can actually note that you're not sure that it's an involuntary movement. And so I think that gives you a really good anchor point for then the next time that you screen or evaluate the patient, and can really decide whether things look very different. And it might have only changed in 1 or 2 areas, but at least you've got the rating scale to then refer back to. Another interesting part of the AIMS is that it allows you to give a global assessment of how this is impacting a patient, how severe are the movements, and whether patients are actually aware of their movements or not. And so that can also guide you in your future ongoing evaluations of the patient. So very useful scale.
And then there's also the assessment at rest, when you let the hands hang, but you also do some activation, because when you distract people or activate them, then on the contralateral hand or in the tongue that they stick out, or the open mouth, you will ultimately see the movements. You do it sitting, you do it standing, because gravity also can bring out the movements. And it's important to actually look at a video and get trained by people who have been doing it, so that you become proficient. And even though you might think, oh, it's extra time, the more you do it, the easier it really is. And once the patients know what you're asking them to do, this can be done in 2 minutes, no time. Now, in terms of the criteria, the School-Arcane criteria would say you need 2 mild body region or 2 scores of mild or 1 moderate as a minimum scale performance. And if it's sometimes borderline, that might be a beginning. And as you mentioned, you might note it down and next time have another assessment, not waiting for 6 months so that you catch it actually early enough. Yeah. Now, Juhi, it's important for all clinicians to involve the patients and caregivers, as you said, in assessing and getting the history of that, but also in the shared decision-making. So what insight can you provide to your audience relative to incorporating the shared decision-making strategies when dealing with TD?
I think the first part of shared decision making is communication, right? And so having that conversation with patients, not only because you were vigilant and noticed something, but then, to actually communicate what you're noticing and seeing to the patient. I think in the context of doing that, you can also discuss, the prevalence of the condition and risk factors for it, and what are some of the probabilities and reasons behind why patients might experience this. And I think that sort of basic understanding is an important place to start in that shared decision-making process. After that, you kind of need to understand from the patient's perspective, what is bothering them about these movements and what their goals for treatment might be. Maybe their goal is that they don't necessarily need treatment and they want to monitor it, and that's perfectly okay, but you won't know that until you have that conversation and consider it. You also want to have a sense of what the patient's risk tolerance is, and that may have particular implications for what therapeutic strategy you implement, and also just what their preferences are. And, there's different ways to treat tardive dyskinesia, although there are some preferred methods. But, patients who may be dealing with multiple different aspects of this condition may have specific preferences for how they want it addressed. And then lastly, you really want to have that collaborative discussion with the patient about the expectations of treatment. Sometimes you can sort of help patients understand that they can continue to take their underlying medications so that they don't risk decompensation of their psychiatric disease while you're treating their tardive dyskinesia. So that can be reassuring for a lot of patients. Helpful to discuss adherence with them. No treatment for anything is going to work if you don't take the medications regularly. And then also to communicate with them your strategy and your schedule for monitoring them over time. And, I think patients feel very reassured if there is, a sense of kind of going through this together and having a kind of collaborative treatment plan in the long term.
That was wonderful. A great summary of what shared decision making is: to communicate, to elicit the preferences and consider them, and then to collaborate. So Juhi, thank you very much for this great discussion on the considerable impact of TD and the need for an early, accurate diagnosis to facilitate early intervention. I hope that we've been successful in providing our audience with a few clinical pearls. Let's summarize with our SMART, or specific, measurable, attainable, relevant, and timely goals. That is what we hope that our audience, that is you, will take from this presentation and apply to your practice. We hope that you will identify patients at high risk to develop TD, incorporate the use of rating scales such as the AIMS in conjunction with diagnostic criteria for the assessment and differential diagnosis of involuntary abnormal movements that you might observe or elicit in your patients, and incorporate shared decision-making. These strategies to improve patient communication about the impact of TD and empower engagement in treatment planning. Thank you so much for joining us today for episode 1 of our 2-part CMEO-CAST series. To view an additional episode on the treatment of tardive dyskinesia and other neuropsychiatric conditions, please visit the Neuropsychiatric Hub at www.cmeoutfitters.com. Both episodes and a wide variety of education and resources on neuropsychiatric disorders for both healthcare providers and patients are available on the CME Outfitters Neuropsychiatric Education Hub. Juhi, thank you again for joining me today.
Thank you.
And I would like to thank you, our audience, for joining us. Be safe and take care of yourselves so you can provide the best care for your patients.